Welcome back to the Deep Dive. Today we are really embarking on something fundamental, highly specific, and absolutely critical. We're aiming for true mastery in pediatric respiratory health.
Exactly. This isn't just a quick overview.
No, definitely not. We're synthesizing all this complex developmental and clinical information, trying to really grasp the core differences between a child's airway and an adult's.
And you have to approach it with that mastery mindset, like you said, because the stakes are just so incredibly high.
Right.
The pediatric respiratory system, it's defined by developmental immaturity, profound anatomical differences. I mean, think about the tiny radius of those airways. It means disease can progress at a truly alarming speed. Plus, there's this reliance on specific physiological mechanics that, they only really exist in those first few years of life.
So we're diving deep today. Our sources cover, pretty much everything from the fetal transition metrics all the way to the nitty-gritty of chronic disease management.
That's the plan, a comprehensive look.
Okay, let's start at arguably the most dramatic beginning possible, developmental physiology. Section 2 in our sources, all about that massive transition from fetal life to breathing air. We really need to understand how the fetus handles gas exchange before we can tackle what happens when things go wrong.
Absolutely. Fetal gas exchange is completely outsourced, right, to the placenta.
Totally reliant.
And what's fascinating, truly fascinating, is that the fetal oxygen tension stays remarkably constant. It's shielded, independent of, short-term fluctuations in the mother's oxygen levels.
Yeah.
It's just a beautifully reliable system.
And there's this continuous physiological priming happening in utero, isn't there? Preparing for the outside world.
Precisely. You mentioned priming the chemical environment.
Yes, specifically that.
Well, look at the carbon dioxide tension. It actually falls quite significantly. Starts around, 35 millimeter Hg early in gestation, drops down to about 28 millimeter Hg by term. And that drop is crucial. It fundamentally shifts the acid-base balance, essentially getting the fetal blood and, importantly, the chemoreceptors ready for that big switch needed for the first breath.
And the oxygen transport itself is specialized too, right? Fetal blood needs to be, almost selfish with oxygen to make sure enough gets delivered to the tissues.
Selfish is the perfect word for it, yeah. This is where we need to look at the oxygen dissociation curve, and specifically the role of something called 2U13-diphosphoglycerate, or 213-DPG.
Okay, 213-DPG.
In adult red blood cells, 2A13-DPG acts to decrease oxygen affinity. It basically tells hemoglobin, let go of the oxygen easily to the tissues.
Right, helps offload it.
But fetal hemoglobin, it's relatively insensitive to 2POR3-DPG.
Oh, okay.
Yeah, that difference means fetal blood holds onto oxygen much tighter, ensuring it stays saturated even when the oxygen pressure around it is lower.
So if the fetal hemoglobin is gripping the oxygen so tightly, how does it actually release it to the tissues that desperately need it? There must be a counter mechanism.
There is, and it's quite elegant. It's the local environment in the fetal tissues. You have high levels of carbon dioxide there, resulting in a lower pH.
Right, more acidic.
Exactly. And that localized acidity shifts the dissociation curve slightly to the right, just at the tissue level. That allows for adequate oxygen offloading right where it's needed most. It's a system perfectly designed for that low oxygen, high resistance fetal environment.
Then comes the moment of birth and boom, everything flips. Right. But before the lungs can even start working properly, they need this critical protein lining the air sacs. Surfactant? Let's strip away the jargon. What's its core job?
Surfactant's job is essentially to act like a non-stick coating for the alveoli. Think of the lungs as millions of tiny, moist balloons.
Okay.
Water creates immense surface tension, right?
Yeah.
Which naturally wants to make those tiny balloons collapse. Surfactant, which is a mix of proteins and lipids, dramatically decreases that surface tension.
It stops them sticking together and collapsing.
Precisely. It imparts what we call finite elasticity and, crucially, lowers the massive pressure needed to physically inflate the lungs for the first time.
And without that coating, the lungs are just stiff, almost useless. I know the source material really highlights the timing of its development.
Yes, the timing is critical. Before about 28 to 32 weeks of gestation, the lungs simply tend to collapse. They can't retain air, no matter the baby's size.
So even if surfactant is detectable earlier?
Right. It's detectable maybe around 24 weeks, but the significant increase in the quantity needed for independent breathing, that really ramps up closer to full term.
And its deficiency is the direct cause.
It is respiratory distress syndrome, or RDS. Directly leads to it.
That first breath, then, must be an incredibly forceful event, physiologically speaking. What actually triggers the baby to take that breath, and just how much effort does it involve?
Well, the triggers are key. You get this sudden increase in chemoreceptor sensitivity combined with the mild hypoxia and the sudden hypercapnia, the CO2 buildup that happens the moment the placental oxygen supply is cut.
Okay, the chemical signals are there.
But the physical requirement, it's astonishing. Remember, the lungs were filled with fluid. That fluid has to be rapidly absorbed by the lymphatics or literally squeezed out through the mouth.
Right.
And that very first gasp requires generating an intrapleural negative pressure, a sucking force of anywhere between 40 to 100 centimeters of water pressure.
100 centimeters H2O? That is a staggering amount of force. Why so high?
It's because the initial lung compliance, the stretchiness, is almost non-existent. We're talking maybe 1.5 ml/meter H2O right at birth.
So like trying to inflate something really stiff.
Exactly. Imagine trying to blow up a brand new stiff leather balloon. It takes immense initial pressure just to overcome that surface tension and pop open all those tiny airways.
But the body adapts incredibly quickly.
It's the definition of rapid adaptation. That compliance, the ease of inflation, it increases fourfold, jumping up to around 6 ml/meter H20 within just the first few hours of life.
As the surfactant spreads out.
As it distributes fully and the lungs stabilize, and the resting lung volume also increases, reaching about 80 milliliters within 24 hours, getting closer to the total newborn capacity of roughly 150 milliliters.
Okay, so now they're breathing air, their metabolism is kicking into high gear. Oxygen requirements basically double, right? Compared to adults, weight for weight.
They absolutely do. Newborns are extremely metabolically active relative to their size. They need about 7 milliliters of oxygen per minute per kilogram. That's nearly twice the adult requirement.
And to handle that, initially their breathing is less efficient.
That's right. It's partly due to the relative size of their conducting airways, the dead space.
Where air goes but no gas exchange happens.
Exactly. The dead space volume is around 2 milliliter QA. If you figure their tidal volume, the amount per breath is maybe 20 milliliter. It means roughly 35% of each breath is technically wasted air. In adults, it's closer to 30%.
So slightly less efficient.
Coupled with some initial mismatch between ventilation and blood flow, yeah, it means they're working harder initially to get their blood oxygenated.
But the correction happens fast. What's the timeline for normalizing those arterial blood gases?
The initial relative hypoxia, the low oxygen, that gets sorted very quickly, usually within about 5 minutes.
Okay.
The hypercapnia, the high CO2, takes a bit longer, maybe normalizing by 20 minutes or so.
And the acidosis?
The metabolic acidosis, which is partly from high lactate levels due to the stress of birth, that takes the longest, usually corrects over a full 24 hours. But they have an advantage that higher hemoglobin concentration helps carry more oxygen while the ventilation system is still settling in.
It's amazing how much happens in those first critical minutes. It's also interesting that their oxygen targets aren't quite adult levels immediately.
No, they're not. Arterial PaO2 starts around 75 millimeter Hg in a newborn. It actually takes until the child is about 5 years old to reach that typical adult level of 95 millimeter Hg. It's a gradual maturation process, not an instant switch.
Okay, so we've laid the foundation. Let's use the vulnerability of that small developing system as our bridge into Section 3, decoding the common respiratory symptoms that often, understandably, send parents into a panic. And number one on the list is always the cough. We're taught it's a defense mechanism, but how do we, as clinicians or informed listeners, decide when to manage it versus when to let it do its job?
Right. The cough is the primary airway defense. It's initiated by a center in the medulla, responding to often impulses, signals coming in usually via the vagus and glossopharyngeal nerves because something is irritating the airway.
Like mucus or foreign material.
Exactly. Pharynx, larynx, trachea, bronchi, even the pleura. The response is that sudden, explosive release of air after taking a deep breath through a partially closed glottis driven by expiratory muscles.
And the source material gives a very strong warning here. Do not suppress a cough unnecessarily in young children.
This is absolutely critical for mastery. Suppressing a productive cough, especially in a young child with an infection, causes retention of those infected secretions right down in the trachea and bronchi.
Which leads to complications.
Serious complications. Most notably, atelectasis, the collapse of a section of the lung. However, we do need to balance this, right? A persistent hacking cough that's causing vomiting, preventing sleep, or leading to significant fatigue. That does need some management, even if we try to avoid strong suppressants initially.
Okay, let's break down the causes. The difference between a straightforward acute cough and that much more worrying list of chronic or recurrent causes.
Acute coughs are usually pretty straightforward to attribute. The common cold, acute pneumonia, maybe the start of something specific like measles or whooping cough.
Things that resolve relatively quickly.
Generally, yes. But when a cough becomes chronic or recurrent, persists for weeks, or keeps coming back, we have to broaden our thinking significantly. We need to consider structural issues or systemic problems.
Like what specifically?
We start looking for chronic inflammatory conditions like asthma, obviously, or maybe tropical eosinophilia. Then there are suppurative diseases, conditions involving pus formation like cystic fibrosis, bronchiectasis, or a chronic lung abscess.
Okay.
We also think about structural abnormalities. Things like primary ciliary dyskinesia, where the tiny cilia lining the airways don't work properly and can't clear mucus, or even something like an H-type tracheoesophageal fistula, a small connection between the trachea and esophagus that allows food or fluid to leak into the windpipe, causing persistent irritation and cough. And we can't forget a retained foreign body.
We mentioned earlier that young children typically just swallow their respiratory secretions. So if a child actually starts expectorating, coughing up sputum, what does that signal clinically?
It's usually a big red flag for chronicity. Significant expectoration in a child strongly suggests a more severe, likely long-standing problem. We're thinking bronchiectasis, a chronic lung abscess, maybe active tuberculosis.
And the sputum itself gives clues.
Definitely. The nature and amount are highly diagnostic. For example, thick, purulent, copious sputum, especially noticeable first thing in the morning, suggests it's been pooling overnight. That points heavily towards bronchiectasis.
And then the most immediately alarming symptom, hemoptysis, coughing up blood.
Yeah, hemoptysis demands immediate, thorough investigation, no question. The potential causes range from local tissue destruction, like in necrotizing pneumonia or cavitary TB, to systemic issues like a bleeding disorder.
Or something irritating the airway lining.
Exactly, a foreign body that's eroded the tissue. Or even rare conditions like idiopathic pulmonary hemosiderosis, where there's bleeding into the lung tissue itself.
Okay, moving on to decoding the symphony, or maybe cacophony, of abnormal respiratory sounds. The source gives us a really brilliant rule of thumb, a dictum, about the relationship between the sound's characteristics and where the obstruction is located.
That dictum is absolutely key for localizing the problem quickly. It states, pitch increases and intensity decreases as the origin of the sound moves lower down the respiratory tract.
Okay, say that again, pitch up, intensity down as you go lower.
Exactly. Think about it logically. Snoring originates way up in the large, relatively floppy oropharynx, so it's loud, low-pitched, and often irregular. Now compare that to a wheeze. A wheeze comes from the small, tight bronchioles deep inside the chest, so it's high-pitched, almost musical, but less intensely loud when you listen at the mouth compared to snoring.
That makes sense. And where the sound occurs in the breathing cycle, inspiration or expiration also tells us about the location.
Precisely. Obstruction outside the chest cavity, extrathoracic obstruction, meaning the upper airway like the larynx or high trachea, causes problems mainly during inspiration. That generates inspiratory sounds, the classic one being stridor.
Okay.
Obstruction in the distal airways, down in the bronchioles, inside the chest, causes problems predominantly during expiration. That's because airways naturally narrow a bit during exhalation anyway. So that generates expiratory sounds, the main one being wheeze.
And if it's in the major airways inside the chest?
Obstruction in the major intrathoracic airways, like the main bronchi or trachea within the chest, can cause abnormal sounds during both inspiration and expiration.
Let's focus on the wheeze for a moment.
Yeah.
Beyond the obvious cause, asthma, what are the critical differentials we absolutely must consider, especially for mastery?
Right. Wheezing is caused by partial obstruction or narrowing of those smaller airways, the bronchi or bronchioles, and it requires enough airflow to actually vibrate the airway walls and make the sound. Besides the really common causes like viral infections, heightening sensitivity, or causing bronchospasm, and of course asthma,
Which we'll get to.
we have to think about things like tropical eosinophilia. This often mimics chronic asthma, presents with wheeze and high eosinophil counts, and it's linked to nematode migration, believe it or not.
Oh, okay.
And similarly, Loeffler syndrome, which is specifically caused by the passage of Ascaris larvae, a type of roundworm, through the pulmonary capillaries during their life cycle, causes inflammation and wheeze.
And what about the single most dangerous differential diagnosis for a wheezing child? The one you cannot afford to miss.
The inhaled foreign body. This is a life-saving distinction. A foreign body aspiration typically presents with sudden onset symptoms, choking, gagging initially, maybe followed by a quieter period. But the absolute key is often a unilateral, localized wheeze. You might hear diminished breath sounds on just one side.
Unlike asthma or bronchiolitis.
Exactly. Asthma or bronchiolitis causes widespread bilateral wheezing because the inflammation is diffuse. If you hear a persistent wheeze localized to one area of the chest, especially with sudden onset, you must think foreign body first.
Okay, critical point. Now shifting upwards to stridor, that high-pitched, harsh sound indicating upper airway obstruction in the larynx or trachea. Why are infants so particularly vulnerable to developing stridor?
It really comes down to the infant's anatomy. Their larynx is naturally small. The submucous tissue around the glottis, the vocal cord area, is very loose and prone to swelling rapidly with inflammation.
Like a sponge.
Pretty much. And crucially, the cricoid cartilage area, which forms a complete ring just below the vocal cords, is the narrowest part of the airway in an infant, and it's rigid. It can't expand. So even a small amount of swelling there causes a massive increase in resistance to airflow very, very quickly.
So we need to differentiate acute, potentially life-threatening stridor. Table 15.2 in the source compares supraglottic obstruction, mainly epiglottitis, versus subglottic obstruction, like infectious croup.
This distinction is absolutely vital in the emergency setting. It dictates immediate management. Epiglottitis, affecting the structures above the vocal cords, supraglottic, is typically a bacterial emergency. Historically, Haemophilus influenza type B, though less common now with vaccination, it progresses terrifyingly fast, often in just hours.
And the clinical picture is different.
Very different from croup. The child with epiglottitis often has a muffled cry or voice, significant difficulty swallowing leading to drooling, and maybe less severe outward respiratory distress initially, but they look extremely toxic, very ill. Subglottic obstruction, mainly infectious croup, affecting the area below the vocal cords, is usually viral. The key differentiator here is often a normal-sounding cry, but accompanied by that classic, deep, barking, brassy cough. The onset is usually more gradual, too.
That distinction is crucial for immediate action. Yeah. What about chronic stridor? That suggests a more persistent, probably structural issue, right?
Generally, yes. By far the most common cause of chronic stridor in infants is congenital laryngeal stridor, also called laryngomalacia.
Laryngomalacia.
It's basically due to floppiness or immaturity of the laryngeal structures, particularly the epiglottis and arytenoid cartilages, which collapse inwards during inspiration. It usually shows up in the first couple of weeks of life, gets worse with crying or feeding.
But the good news is,
it almost always resolves spontaneously as the cartilage firms up, typically by 6 to 12 months of age. But we can't forget other causes of chronic stridor, like external compression, a vascular ring, for example, an abnormal blood vessel configuration encircling the trachea and esophagus. This can cause intermittent stridor that, paradoxically, often gets worse when the neck is flexed because it increases the compression. Infants with this sometimes instinctively hyperextend their necks to try and open the airway.
how do we pin down the diagnosis for these chronic issues?
For suspected laryngomalacia, direct laryngoscopy looking directly at the larynx with a scope is needed to visualize the floppy structures collapsing. If we suspect an extrinsic cause like a vascular ring, we typically need imaging like fluoroscopy after a barium swallow. The barium outlines the esophagus and can show the indentation from the external compression, which often affects the trachea too.
Got it. Okay, let's quickly touch on dyspnea. This is distinct from just rapid breathing, tachypnea. Dyspnea implies difficult or labored breathing, often with a feeling of air hunger or even pain. Why is it important to remember this isn't always just a lung problem?
Absolutely crucial point that the source reminds us that while respiratory causes are common, think hyaline membrane disease and newborns, pneumonia, pneumothorax, we must always consider other systems.
Oh, like the heart.
Cardiovascular issues are a big one. Myocarditis, congestive heart failure can present with significant dyspnea. And then there are miscellaneous causes. Severe anemia reduces oxygen carrying capacity, leading to air hunger. Metabolic acidosis, say from diabetes or kidney failure, drives rapid breathing that feels like dyspnea.
Even neurological issues.
Yes, conditions like myasthenia gravis affecting respiratory muscle strength, or even something like Pickwickian syndrome, obesity, hypoventilation can cause dyspnea. The feeling of air hunger can originate far from the lungs.
Okay, good reminder. Moving into section 4, upper respiratory tract infections, or URTIs. Starting with the absolute most common. Nasopharyngitis, the common cold. Usually viral. The main challenge here seems to be distinguishing it from allergies.
Exactly. Allergic rhinitis typically features clear, thin, mucoid nasal discharge, lots of sneezing, maybe itchy eyes, but the key differentiating features are the absence of fever and usually no clear history of contact with someone who is sick.
Where's a cold?
A cold, typically caused by viruses like rhinoviruses, adenoviruses, RSV, or influenza, usually does involve fever, general irritability, maybe sore throat, and nasal obstruction with discharge that might start thin and clear but can thicken and become yellowish or greenish over a few days. That color change doesn't automatically mean bacterial infection, by the way.
Right. In terms of managing the common cold in young children, what are the absolute don'ts? What treatments should be avoided?
Symptomatic relief is the goal. Rest, fluids, maybe saline nose drops to help clear congestion, paracetamol or ibuprofen for fever or discomfort. But we must strictly avoid over-the-counter nasal decongestant sprays or drops like those containing xylometazoline or oxymetazoline in young children.
Why is that?
Because of the significant risk of rebound congestion, known as rhinitis medicamentosa, when the drug wears off, the congestion can become even worse than before, leading to overuse and dependency.
Okay, no decongestant sprays. What else?
We also strongly advise against routine use of cough syrups, especially in infants and toddlers. As we discussed, suppressing the cough can be harmful, and many combination cold remedies contain multiple ingredients that aren't necessary or might have side effects.
And antibiotics.
Absolutely not for a typical viral cold. Antibiotics only have a role if there's clear evidence of a secondary bacterial infection, like acute otitis media or bacterial sinusitis, which might be suggested by prolonged symptoms, worsening fever after initial improvement, or specific signs on examination. But for the uncomplicated cold, they're useless and contribute to resistance.
Okay, clear guidelines there. Next up, acute tonsillopharyngitis, the classic sore throat. Why is making the clinical distinction between a viral cause and group A streptococcus, strep throat, so incredibly vital here?
It boils down entirely to preventing the serious, non-suppurative, immune-mediated complications of untreated or inadequately treated group A strep infection.
Namely,
Acute rheumatic fever, which can cause permanent heart valve damage, and post-streptococcal glomerulonephritis affecting the kidneys. These are devastating consequences that are largely preventable with appropriate antibiotic treatment for strep.
so how do we tell them apart clinically before getting a test?
There are some classic patterns, though they're not perfect. Viral pharyngitis often has a more gradual onset, maybe lower-grade fever, and crucially is often accompanied by other signs of a viral URTI, like cough, hoarseness, runny nose, rhinitis, or conjunctivitis, pink eye.
Okay, so those associated symptoms suggest viral.
Generally, yes. Streptococcal pharyngitis, on the other hand, tends to have a more abrupt onset, often with higher fever, significant throat pain, sometimes headache or abdominal pain. Clinically, you might see swollen tonsils, often with white patches or exudates, and tender swollen lymph nodes in the neck. The key distinguishing feature clinically is often the absence of those other viral symptoms like cough, significant runny nose, or conjunctivitis.
If you see exudates, high fever, tender nodes, and no cough or runny nose, think strep strongly.
That's a very good rule of thumb for raising suspicion, but definitive diagnosis really relies on testing.
A throat swab for rapid antigen testing or culture. And if it is strep, the treatment needs to be rigorous.
Absolutely. The standard treatment is a full 10-day course of penicillin V taken orally, or sometimes a single injection of long-acting benzathine penicillin G. For penicillin-allergic patients, oral erythromycin or another macrolide is the usual alternative. Completing the full 10 days, even if the child feels better sooner, is non-negotiable to ensure eradication of the bacteria and prevent those immune complications.
And some antibiotics should be avoided.
Yes, the source specifically mentions that fluoroquinolones and trimethoprim sulfamethoxazole, cotrimoxazole, are generally contraindicated for treating strep pharyngitis due to resistance patterns and lack of proven efficacy in preventing rheumatic fever.
What if a child keeps getting recurrent strep infections? Does that imply something else is going on?
It certainly warrants a closer look. We need to make sure each episode is truly culture-proven strep, not just recurrent viral sore throats. We should also examine for other potential sources of chronic infection or inflammation, like chronic sinusitis or issues with the ears.
Environmental factors.
Definitely consider environmental factors. Exposure to cigarette smoke, damp living conditions, overcrowding these can all potentially increase susceptibility. For truly recurrent, frequent, culture-proven strep infections, sometimes long-term low-dose penicillin prophylaxis for 3 to 6 months might be considered to break the cycle.
What about tonsillectomy? Isn't that done for recurrent tonsillitis?
Tonsillectomy is not considered a primary prevention measure for rheumatic fever. Its role is much more limited now. It might be considered in cases of very frequent, severe, debilitating episodes of bacterial tonsillitis that significantly impact the child's quality of life, or if there's been a peritonsillar abscess, quinsy. But it's not a routine solution for recurrent strep.
Okay, that clarifies the role of tonsillectomy. Section V brings us back down the airway to the croup syndromes. Let's move past the general definition and dive into the clinical management, starting with the most feared, epiglottitis.
Right. Epiglottitis, or more accurately, supraglottitis as it involves structures around the epiglottis, is the true pediatric airway emergency. It's typically bacterial, historically H. influenza type B, though other bacteria can cause it. The key is its rapid progression. We're talking deterioration over mere hours.
And the clinical picture is quite distinct if you know what to look for.
Very distinct. The child usually appears acutely ill, toxic, with a high fever. They often adopt a characteristic posture, sitting bolt upright, leaning forward, neck extended, mouth open, and often drooling because swallowing saliva is too painful and difficult. This is sometimes called the sniffing position or tripod position.
And the voice is affected differently than in typical croup.
Yes, instead of a hoarse voice or barking cough, they often have a muffled hot potato voice, or maybe unable to phonate much at all due to the swelling above the vocal cords.
And the source gives a critical, potentially life-saving warning about examination.
Absolutely paramount. Never, under any circumstances, should you attempt an injudicious examination of the throat, like using a tongue depressor in a child where you suspect epiglottitis, especially outside of a controlled setting like an operating room.
Why not?
Because the stimulation from the tongue depressor can trigger a sudden, complete laryngeal spasm, a reflex spasm of the airway muscles leading to immediate fatal airway obstruction. Examination should only be done by experts prepared for immediate intubation.
So management has to be swift and aggressive.
Immediate hospitalization is mandatory. Keep the child calm, often in the parent's lap. Provide humidified oxygen, usually by face mask held near the face rather than strapped on if it causes distress. Secure 5E access carefully for fluids and antibiotics.
Which antibiotics?
Broad-spectrum antibiotics covering likely pathogens are started immediately, typically a third-generation cephalosporin like ceftriaxone or cefotaxime, and crucially, an anesthesiologist and otolaryngologist, ENT surgeon, should be involved immediately for airway management.
Intubation is often needed.
Very often. If the obstruction is significant or worsening, controlled intubation in the operating room is the safest approach. Occasionally, if intubation isn't possible, an emergency tracheostomy might be required, but prompt diagnosis and treatment usually prevent that.
Okay, a true emergency. Now let's contrast that with the much more common infectious croup, also known as laryngotracheobronchitis, LTB. This is usually less severe and typically viral, right?
Yes. Infectious croup is overwhelmingly viral, with parainfluenza virus type 1 being the most common culprit, though other viruses like RSV, influenza, and adenoviruses can also cause it. It involves inflammation and swelling below the vocal cords in the subglottic area.
And the onset is different.
Much more gradual than epiglottitis. Typically, the child has symptoms of a regular cold, runny nose, maybe a low fever for a few days before the characteristic croup symptoms develop.
Which are?
The hallmark triad is a harsh, barking, seal-like cough, inspiratory stridor, that high-pitched noise on breathing in, and hoarseness. The severity can range from mild, with stridor only when upset, to severe, with stridor at rest and significant respiratory distress.
As the airway swelling gets worse, what signs of increased work of breathing do we see?
You start to see retractions, sucking in of the skin between the ribs, intercostal, below the ribs, subcostal, or above the collarbone, supraclavicular. The child might become tachypneic, breathing faster, restless, or agitated due to hypoxia or the effort of breathing.
Now, there's a dangerous paradoxical sign of worsening obstruction that clinicians absolutely must be trained to spot. What is that?
This is a critical point for mastery, often missed. As the airway obstruction becomes extremely severe, the child simply cannot move enough air in or out to generate the vibrations needed to make the stridor sound.
So the stridor might seem to decrease.
Exactly. The stridor may apparently lessen, or the breath sounds might become very quiet or almost inaudible. This is not a sign of improvement. It's a sign of impending respiratory failure due to exhaustion and critical airway narrowing. It requires immediate, aggressive intervention.
Okay, so decreasing stridor in a tired, distressed child is an ominous sign. How do we generally triage the severity of croup and decide on treatment? There are scoring systems, and what are the key elements?
We assess based on several factors. The child's general appearance, are they happy and playful, or restless, agitated, or lethargic? The severity of the stridor, is it only when coughing, crying, or present at rest? The degree of respiratory distress, presence and severity of retractions, respiratory rate, and importantly, their oxygen saturation level.
And treatment depends on severity.
Oh, absolutely. Mild croup, where stridor is only present with agitation and there's no distress at rest, can often be managed at home with supportive care, cool mist, fluids, keeping the child calm.
But moderate to severe cases need more.
Yes. Moderate croup, stridor at rest, mild to moderate retractions, little agitation, and severe croup, significant stridor at rest, severe retractions, agitation, or lethargy, potential cyanosis, require hospital assessment and treatment.
What's the cornerstone of treatment for moderate to severe croup?
The mainstay is corticosteroids. A single dose of oral dexamethasone, typically 0.6 mg/kg, though doses from 0.15 to 0.6 mg/kg are used, is recommended for almost all children presenting for care, even those with mild symptoms, as it reduces the inflammation and swelling and decreases the need for hospitalization or return visits. Inhaled budesonide via nebulizer is an alternative if the child can't take oral medication.
What about immediate relief for significant distress?
For moderate to severe distress, nebulized epinephrine adrenaline is used. It works rapidly via vasoconstriction, shrinking the swollen mucosa in the airway and providing temporary relief, usually within 10-30 minutes. We typically use the standard 1.1000 dilution. The effect is temporary, lasting maybe 1-2 hours, which is why the steroid is crucial for longer-lasting effect. Patients receiving epinephrine need observation for a few hours afterwards to ensure symptoms don't rebound.
Okay, so steroids for the inflammation, epinephrine for acute obstruction relief. Section 6 takes us deeper into the lungs. A deep dive into pneumonia. We need to remember right off the bat that the likely cause, the etiology, is very much an age-dependent target here.
It absolutely is. And while globally, viruses like RSV and influenza account for a significant portion, maybe 40% of cases overall.
Bacterial causes are still dominant in severe cases.
Bacterial causes are thought to account for maybe 2/3 of the really severe cases, especially those requiring hospitalization, which is why understanding bacterial pathogens and antibiotic treatment is so critical for reducing mortality.
And we also have to acknowledge the major risk factors, especially in resource-limited settings, that drive such high mortality from pneumonia.
Yes, factors like low birth weight, malnutrition, especially vitamin A deficiency, lack of breastfeeding, exposure to passive smoking, household crowding, and crucially, indoor air pollution from cooking fuels. These are major drivers of pneumonia incidence and severity in many parts of the world.
Okay, let's break down the likely bacterial pathogens based on age, as this guides initial empirical antibiotic choices.
Right. In the youngest infants, newborns less than maybe 2 months old, we worry about pathogens acquired during or shortly after birth. This includes gram-negative organisms like E. coli and Klebsiella, as well as group B streptococcus, acquired from the mother. Staphylococcus aureus and Streptococcus pneumonia, pneumococcus, are also considerations.
Okay, a broader range in newborns. What about infants and young children, say 3 months to 3 years?
In this age group, the picture changes. Streptococcus pneumonia becomes the most common bacterial cause. Haemophilus influenza type B used to be major here, but Hib vaccination has dramatically reduced its incidence, though non-typable strains still cause disease. Staphylococcus aureus remains a concern, especially for severe necrotizing pneumonia.
And older children, over 3 or 4 years, and adolescents.
Pneumococcus and Staph aureus are still important, but this is the age group where the atypical bacterial pathogens become much more common, specifically Mycoplasma pneumonia and Chlamydia pneumonia.
And we can't forget opportunistic infections in certain groups.
Exactly. In immunocompromised children, we have to consider organisms like Pneumocystis jirovecii, formerly PCP, or fungi like Histoplasma.
Let's contrast the two classic bacterial pneumonias, pneumococcal, S. pneumonia, versus staphylococcal, because their pathology and presentation can be quite different. Start with pneumococcus.
Pneumococcal pneumonia is often considered the classic example of lobar or lobular consolidation. The bacteria multiply rapidly within the alveoli, triggering a significant inflammatory response. This leads to an outpouring of protein-rich fluid, red blood cells, and white blood cells, mainly neutrophils, into the air spaces.
Filling up the alveoli.
Exactly, filling them up and causing the lung tissue in that area to become solid or consolidated. This typically affects a distinct lobe, lobar pneumonia, or patches within a lobe, lobular pneumonia, or bronchotop pneumonia.
And clinically?
The onset is often abrupt, with high fever, chills, headache, and cough. The cough might initially be dry, but often progresses to producing sputum, which classically can be thick and rust-colored due to the presence of altered blood. Chest pain, often sharp and worse with breathing, pleuritic, is common. Sometimes the pain can be referred to the shoulder or even the abdomen if the inflammation irritates the diaphragm.
And on examination?
You'd look for signs of consolidation in the affected area, decreased chest movement, dullness when you percuss tap the chest, increased vocal resonance, and characteristic bronchial breath sounds heard over the consolidated lung.
Okay, classic consolidation. Now, staphylococcal pneumonia, especially in infants, is often described as a more destructive process. How so?
It really is. Staph aureus, particularly strains like MRSA, often causes a more aggressive necrotizing pneumonia. Instead of just filling the alveoli, it tends to cause significant tissue destruction, leading to the formation of multiple small abscesses within the lung parenchyma, a diffuse process of bronchoalveolar destruction.
And this destructive process leads to a characteristic radiological sign.
Yes, the formation of pneumatoceles. These are thin-walled, air-filled cystic spaces within the lung. They form when these small abscesses erode into nearby small airways. Air can get in, but the damaged tissue acts like a one-way valve, trapping the air and causing the space to progressively inflate like a balloon. Seeing pneumatoceles on an X-ray is highly suggestive, almost pathognomonic, of staphylococcal pneumonia, especially in an infant.
And staph pneumonia often comes with severe, rapid complications.
It does. Staph infections have a tendency to spread via the bloodstream, leading to disseminated disease with abscesses elsewhere, like in bones, osteomyelitis, or joints, septic arthritis. Pleural complications are also very common and often severe with staph.
Like empyema.
Yes, empyema, the collection of pus in the pleural space, is a frequent complication, and the source highlights a crucial clinical rule of thumb. Empyema, occurring in a child under 2 years of age, is almost always caused by Staphylococcus aureus. Purulent pericarditis is another dangerous potential complication.
So management requires prompt hospitalization and aggressive, prolonged antibiotics.
Absolutely. Given the severity and potential for complications, prompt hospitalization is key. Initial antibiotic choice needs to cover Staph aureus effectively, often including MRSA coverage depending on local resistance patterns. Drugs like cloxacillin or nafcillin for MSSA or vancomycin or linezolid for suspected MRSA are typically used intravenously. And treatment duration is usually much longer than for typical pneumococcal pneumonia, often requiring 2 to 6 weeks of therapy.
Okay, a very different beast. Now, moving to the atypical pneumonias caused by agents like mycoplasma pneumonia, chlamydia pneumonia, or even Legionella, what makes them atypical?
They're called atypical partly because the organisms themselves are different, lacking cell walls, intracellular, etc., partly because the clinical presentation often differs from classic pneumococcal pneumonia, and partly because they don't respond to standard beta-lactam antibiotics like penicillin.
And they tend to affect a different age group.
Yes, mycoplasma and chlamydia pneumonia are uncommon causes of pneumonia in children under about 4 or 5 years old. They become much more frequent in school-aged children and adolescents, often causing outbreaks or epidemics, particularly in the winter months. Transmission is typically via respiratory droplets.
How does the clinical presentation differ? Can it fool you?
It definitely can. The onset is often more insidious or gradual compared to the abrupt onset of pneumococcal pneumonia. Symptoms might start with malaise, headache, low-grade fever, sore throat, and myalgias, muscle aches. The cough is often prominent but typically starts dry and hacking, then might become mucoid, sometimes even blood-streaked, but usually not the thick, purulent sputum of bacterial pneumonia.
And the key finding on examination, or lack thereof.
That's the trick. There's often a dissociation between the symptoms and the physical findings. The child might feel quite unwell and have a persistent cough, but when you examine their chest, you might find surprisingly few signs. Maybe just some mild crackles, crepitations, or wheezes, often not distinct signs of consolidation.
But the chest X-ray tells a different story.
Precisely. The radiological findings in atypical pneumonia are often more extensive than the physical findings would suggest. Instead of dense lobar consolidation, you typically see more patchy or diffuse infiltrates, often described as interstitial or reticulonodular patterns, sometimes radiating out from the hilar regions, frequently involving the lower lobes.
Diagnosis and treatment.
Diagnosis is often clinical, especially during known outbreaks, but can be confirmed with serological tests looking for specific IgM antibodies or sometimes PCR testing on respiratory samples. Since these organisms lack cell walls, beta-lactam antibiotics are ineffective. The treatment of choice is typically a macrolide antibiotic like azithromycin, erythromycin, or clarithromycin, usually for 7 to 10 days. Tetracyclines, like doxycycline, are effective but generally avoided in younger children due to teeth staining.
Okay, before we leave pneumonia entirely, we absolutely must mention the unique challenge in management of aliphatic hydrocarbon pneumonia, most commonly from kerosene aspiration. What's the key pathophysiology here?
Kerosene and similar hydrocarbons have very low viscosity and low surface tension. This means if they are ingested and then aspirated into the lungs, which happens easily, especially if vomiting occurs, they spread very rapidly and deeply into the distal airways and alveoli.
Like water on blotting paper.
Exactly. This causes a severe chemical pneumonitis, direct inflammation, and damage to the lung tissue. Symptoms usually develop quickly after aspiration and include coughing, choking, rapid breathing, fever, and sometimes CNS effects like lethargy or seizures if significant amounts were absorbed systemically.
And the critical management instruction, which seems counterintuitive.
The absolute key instruction emphasized in the source is never induce vomiting and generally avoid gastric lavage in cases of hydrocarbon ingestion.
Why? If they swallowed it, shouldn't you try to get it out of the stomach?
Because the main danger isn't from the kerosene sitting in the stomach, it's from it getting into the lungs. The risk of inducing vomiting or passing a lavage tube, causing aspiration of even a small amount of kerosene into the lungs, is far greater than the risk from systemic absorption from the gut. Aspiration causes the severe lung injury.
So you risk making the most dangerous complication more likely by trying to empty the stomach.
Precisely. The primary injury is pulmonary. Therefore, management is purely supportive, focused on the respiratory effects. Monitor the child closely for respiratory distress, provide supplemental oxygen as needed, and manage any complications like secondary bacterial infection if it occurs. There's no specific antidote. Prevent aspiration at all costs.
Okay, a vital point for anyone dealing with potential ingestions. Let's pivot now to Section 7. Acute respiratory infection, ARI control, focusing on that powerful practical triage system developed by the WHO, especially for settings with high infant mortality where resources are limited.
Yes, this system is a cornerstone of the Integrated Management of Childhood Illness, IMCI, strategy. It's a brilliant public health tool designed for primary healthcare workers in areas where sophisticated diagnostics like X-rays or lab tests might not be readily available.
And the primary goal?
The goal is to quickly identify children with pneumonia who are most likely to have a bacterial cause, estimated to be 50–60% of severe cases in these settings, and ensure they receive life-saving antibiotics promptly, thereby preventing deaths. It relies entirely on simple, observable clinical signs.
And it all hinges on a very specific, age-adjusted definition of fast breathing or tachypnea.
Exactly. Recognizing fast breathing is the first key step. The cutoff depends on the child's age, reflecting the normal decrease in respiratory rate as children get older.
What are the cutoffs?
For an infant under 2 months old, fast breathing is defined as a respiratory rate of 60 breaths per minute or more.
Okay, 60 for under 2 months.
For a child aged 2 months up to 12 months, the cutoff is 50 breaths per minute or more.
50 for 2 to 12 months.
And for a child aged 1 year up to 5 years, fast breathing is defined as 40 breaths per minute or more.
40 for 1 to 5 years, so 60, 50, 40.
Correct. And the other key sign they look for is lower chest wall indrawing, where the lower chest sucks in deeply during inspiration. This indicates significant respiratory effort and likely lung pathology.
So how do these signs, fast breathing and chest indrawing, guide the treatment decisions according to the WHO guidelines, referencing Table 15.4?
It creates clear action pathways. If a child aged 2 months to 5 years has a cough or difficult breathing but does not have fast breathing according to their age cutoff and has no lower chest indrawing or danger signs, they're classified as having a likely URTI, like a cold or perhaps just cough. The recommendation is symptomatic home care fluids, fever relief, advising the caregiver when to return if symptoms worsen.
Okay, no fast breathing, no indrawing home care. What if I do have fast breathing?
If the child does have fast breathing for their age, but does not have chest indrawing or any general danger signs, like inability to drink, persistent vomiting, convulsions, lethargy, stridor when calm, or severe malnutrition, they are classified as having pneumonia.
And the treatment for this pneumonia category?
The recommendation is ambulatory treatment with an appropriate oral antibiotic, typically amoxicillin, usually dosed at 40-50 millikilograms per dose, given twice daily for 5 days. Plus, supportive home care advice.
Okay, fast breathing alone equal oral antibiotics at home. Now, what defines severe pneumonia?
Severe pneumonia is diagnosed if the child has cough or difficult breathing, plus any lower chest wall indrawing, or if they have any of the general danger signs, regardless of whether they have fast breathing or indrawing.
So chest indrawing or any danger sign automatically bumps it up to severe.
Exactly. Danger signs include being unable to drink or breastfeed, vomiting everything, having convulsions, being lethargic or difficult to wake, having stridor when calm, or signs of severe malnutrition. Central cyanosis or oxygen saturation below 90-92% also indicates severity.
And the management for severe pneumonia?
These children require urgent referral and admission to a hospital. Treatment involves supportive care, oxygen therapy if needed, fluid management, and parenteral injectable antibiotics. The first-line recommendation is typically IV or IM, penicillin, or ampicillin, often combined with gentamicin for broader coverage, especially in younger infants.
What about infants under 2 months? Is the classification different?
Yes, for very young infants under 2 months, the criteria are stricter because they can deteriorate very rapidly and signs can be subtle. Basically, any sign of serious illness in this age group warrants urgent hospital referral and treatment for presumed severe bacterial infection. This includes signs like stopping feeding well, convulsions, fast breathing, 60 mins, severe chest indrawing, fever or low body temperature, or being abnormally sleepy or difficult to wake. Any of these classifies as very severe disease or severe pneumonia requiring immediate admission and parenteral antibiotics.
It's a very practical system designed for high-risk environments. Okay, let's move on to bronchiolitis. This is described as the most common lower respiratory tract infection, LRTI, specifically in infants, usually those between 1 and 6 months old. What's the primary cause?
Overwhelmingly, the main culprit is respiratory syncytial virus, or RSV. It causes seasonal epidemics, usually in the winter months. Other viruses like rhinovirus, parainfluenza, human metapneumovirus, and adenovirus can also cause bronchiolitis, but RSV is the dominant player.
Is there any natural immunity? Why are infants so susceptible?
Well, maternal antibodies, IgG, do cross the placenta and offer some protection initially, particularly the IgG3 subclass, which seems important for RSV. However, these antibodies have a relatively short half-life and wane over the first few months of life. Breastfeeding provides secretory IgA antibodies directly to the respiratory mucosa, which does seem to reduce the risk of severe disease requiring hospitalization. But infants' small airways and developing immune systems make them inherently vulnerable.
The pathogenesis of bronchiolitis provides a perfect, almost textbook illustration of how vulnerable those small airways are, and it's tied directly to physics, isn't it?
Absolutely. This is where Poiseuille's law comes into play regarding airway resistance. Bronchiolitis involves inflammation and edema, swelling, of the mucosa lining the very small airways, the bronchioles. This is often combined with increased mucus production and shedding of cellular debris, leading to plugging.
So the tubes get narrower.
Exactly. And airway resistance is inversely proportional to the fourth power of the radius.
Okay, say that again, fourth power.
Yes, R is proportional to 1R4. This means even a small decrease in the radius of these tiny bronchioles causes an exponential increase in the resistance to airflow. If the radius is halved, the resistance increases 16-fold.
Wow, 16 times harder to push air through.
Precisely. And it gets worse during expiration. The bronchioles lack cartilage support, so they naturally tend to narrow or partially collapse during exhalation. With the added swelling and mucus, this expiratory narrowing becomes severely restricted.
Leading to air trapping.
Exactly. Air can get drawn in past the obstruction during inspiration, but it has extreme difficulty getting out during expiration. This leads to progressive air trapping distal to the obstructions, causing hyperinflation of the lungs. You see this as a flattened diaphragm and increased AP diameter on X-ray. This overinflation is essentially emphysema. If an airway becomes completely obstructed by a mucus plug, the air trapped behind it gets absorbed, leading to atelectasis. collapse in that segment.
Clinically, how does this manifest? How does it typically start and progress?
It usually begins like a simple upper respiratory infection, runny nose, cough, maybe a low fever for a few days. Then the respiratory symptoms worsen with the onset of rapid breathing, tachypnea, increased work of breathing, retractions, and often audible wheezing or crackles.
And the hyperinflation has physical signs.
Yes, on examination, the chest might sound hyperresonant when you percuss it due to the trapped air. The hyperinflation can push the diaphragm down, making the liver and spleen feel palpable below the rib cage. Auscultation reveals prolonged expiration, and you typically hear widespread fine crackles, crepitations, wheezes, rhonchi, or both.
How is the diagnosis usually made?
Diagnosis is primarily clinical, based on the typical age, seasonal occurrence, and characteristic signs and symptoms following a URTI prodrome. A chest X-ray isn't always necessary, but often shows signs of hyperinflation, flattened diaphragms, increased lung volumes, and may show patchy infiltrates or atelectasis and bronchial wall thickening, coughing. Rapid diagnostic tests for RSV performed on a nasopharyngeal aspirate can confirm the viral cause, but don't usually change management.
Speaking of management, bronchiolitis is notoriously managed mainly with supportive care.
Yeah.
What are the cornerstones?
The absolute mainstay is supportive care. Ensuring adequate hydration, often with smaller, more frequent feeds or IV fluids if oral intake is poor, is critical. Gentle suctioning of the nasal passages before feeds can help relieve obstruction. The most crucial intervention is supplemental humidified oxygen if the child is hypoxic. The goal is to maintain oxygen saturation consistently above 90-92%.
What about other treatments often used for wheezing, like bronchodilators or steroids?
This is where the evidence is quite clear, and it differs from asthma. Routine use of bronchodilators, like salbutamol-albuterol, is not recommended. While a trial might be considered in some cases, studies generally show they don't significantly improve outcomes like duration of hospitalization or oxygen requirement in most infants with bronchiolitis. Similarly, corticosteroids, inhaled or systemic, have not been shown to be beneficial and are not routinely recommended.
Antibiotics.
Antibiotics have no role in treating uncomplicated viral bronchiolitis. They should only be used if there is strong suspicion or confirmation of a secondary bacterial infection, which is uncommon.
What about ribavirin?
Ribavirin is an antiviral medication that has activity against RSV. However, its use is highly controversial and generally restricted only to infants with severe bronchiolitis who have significant underlying conditions that put them at very high risk, such as congenital heart disease, chronic lung disease like BPD, or severe immunodeficiency. It's expensive, difficult to administer, requires prolonged inhalation, and its clinical benefit is debated.
So primarily oxygen and supportive care. What's the typical prognosis?
Most infants with bronchiolitis recover fully within 1 to 2 weeks. Although cough and mild wheeze can sometimes linger for longer, it's generally a self-limited illness.
Yeah.
However, there's a well-established significant epidemiological link.
The connection to asthma later in life.
Exactly. A substantial proportion of children, maybe up to 1/4 or even more, who have bronchiolitis in infancy, particularly severe cases requiring hospitalization, go on to develop recurrent wheezing episodes or are diagnosed with bronchial asthma later in childhood.
It suggests that perhaps the severe viral inflammation during bronchiolitis might cause some long-term changes or remodeling in the airways, leading to persistent hyperresponsiveness in susceptible individuals.
That's the leading hypothesis, which makes the next section, Section 8 on bronchial asthma, even more critical to understand thoroughly.
Right. So bronchial asthma, it's defined fundamentally by increased responsiveness or hyperreactivity of the airways to various stimuli. This leads to widespread but usually reversible narrowing of the airways, causing the classic symptoms of paroxysmal dyspnea, sudden shortness of breath, wheezing, and cough. What are the 3 core pathological components that simultaneously contribute to this airway obstruction during an asthma attack?
It's really a triple threat causing the narrowing. First, you have spasm of the smooth muscle that surrounds the airways, bronchospasm. Second, there's edema, swelling, and inflammation of the mucous membrane that lines the airways. And third, there's excessive secretion of thick mucus, often mixed with inflammatory cells and debris, which can form plugs and further block the airways.
So controlling asthma effectively means tackling all 3 of those: the muscle spasm, the inflammation swelling, and the mucus production.
Exactly. Effective management targets all these components.
Asthma is often classified broadly. What are the main types or classifications mentioned?
Classically, it's often divided into atopic or extrinsic asthma versus non-atopic or intrinsic asthma. Atopic asthma is clearly linked to allergy, mediated by Ig antibodies against common environmental allergens like dust mites, pollen, animal dander. It often starts in childhood and is associated with other allergic conditions like eczema or allergic rhinitis. Non-atopic asthma doesn't have that clear IgE link, often starts later in life, and triggers might be more related to infections or irritants. However, the underlying inflammation is key in both. The source also mentions the concept of a biphasic response.
The early and late reaction.
Right. After exposure to a trigger, there's often an immediate or early phase reaction, mainly driven by mast cell degranulation, releasing histamine and causing bronchospasm within minutes. But then, several hours later, a late phase reaction can occur, driven by the influx of inflammatory cells like eosinophils, causing more sustained inflammation, swelling, and hyperresponsiveness that can last for hours or even days. Understanding this late phase is crucial for appreciating the need for anti-inflammatory controller medications, not just rescue bronchodilators.
Let's talk about specific triggers. Viral infections are mentioned as key triggers, especially in children. How do they precipitate asthma attacks?
Viral respiratory infections, even the common cold, are probably the single most common trigger for asthma exacerbations in children. The virus directly infects the airway epithelial cells, causing inflammation and damage. This can increase airway sensitivity to other triggers, enhance the underlying inflammatory response, and interfere with the normal mechanisms that regulate airway tone, leading to bronchospasm and mucus production.
What about exercise? Why does physical activity trigger symptoms in many people with asthma?
Exercise-induced bronchoconstriction, EIB, is thought to be primarily caused by the consequences of breathing rapidly during exercise, especially breathing colder, drier air through the mouth. This leads to significant evaporative water loss from the airway lining.
Dehydrating the airway surface.
Exactly. This dehydration increases the osmolarity, the concentration of the fluid lining the airways. This hyperosmolarity acts as a potent stimulus for mast cells and other inflammatory cells in the airway wall, causing them to release mediators like histamine and leukotrienes, which then trigger bronchospasm and inflammation. Using a scarf over the mouth in cold weather or warming up properly can sometimes help mitigate this.
And what about the commonly held belief about food allergies triggering asthma? What does the source material say about the role of food?
The source material is quite definitive on this point for general childhood asthma. While a true IgE-mediated allergy to a specific food can occasionally trigger respiratory symptoms, including wheezing as part of a systemic allergic reaction, anaphylaxis in some individuals, specific food allergies or sensitivities to food additives are considered to play an insignificant role in the overall pathogenesis and day-to-day triggering of chronic asthma in the vast majority of children.
So expensive elimination diets are generally not helpful unless there's clear evidence of a specific food allergy causing immediate respiratory symptoms?
Correct. The focus should be on identifying and managing inhaled allergens and irritants, viral infections, and using appropriate controller medications, rather than broadly restricting diet in most children with asthma.
Other triggers mentioned include weather changes and emotions.
Yes, sudden changes in weather, particularly exposure to cold, dry air, can act similarly to exercise by causing evaporative water loss. Weather changes can also affect levels of airborne allergens like pollen or mold spores. Emotions like stress or even laughter can also trigger symptoms in some individuals, likely mediated via neural pathways, possibly involving the vagus nerve, which can influence airway smooth muscle tone.
When assessing a child having an asthma attack, what are the severe warning signs we need to look for? And importantly, what about the paradoxical sign of the silent chest?
During an acute exacerbation, we look for signs of increased respiratory effort, use of accessory muscles in the neck and chest, nasal flaring, severe retractions. Profuse sweating and visible apprehension or anxiety are also common. More severe warning signs include cyanosis, bluish discoloration of lips or skin, indicating significant hypoxia. Pulsus paradoxus, an exaggerated drop in systolic blood pressure during inspiration, can indicate severe airflow obstruction and increased intrathoracic pressure swings. Cardiac arrhythmias can also occur due to hypoxia or effects of medication.
And the silent chest. Remind us why that's so dangerous.
This is a critical, potentially fatal sign that every clinician must recognize. Wheezing, although abnormal, indicates that air is still moving through narrowed airways. The silent chest occurs when the airflow obstruction becomes so severe that air movement is drastically reduced or stops altogether. The child might be making maximal respiratory effort, look exhausted, and be cyanotic, but you hear no wheezing on auscultation.
Because not enough air is moving to make the sound.
Exactly. It signifies near complete airway obstruction and impending respiratory arrest. It is not a sign of improvement. It's a sign of extreme severity requiring immediate aggressive intervention.
How is asthma typically diagnosed definitively beyond the clinical history? What role do pulmonary function tests, PFTs, play?
The diagnosis is often strongly suggested by the clinical history, that pattern of recurrent episodes of cough, wheeze, shortness of breath, or chest tightness, especially if it's worse at night or triggered by known factors like exercise or viral infections. PFTs, or spirometry, are crucial for confirming the diagnosis, especially in children old enough to perform the tests reliably, usually over 5 or 6 years old.
What specific PFT results are suggestive or diagnostic of asthma?
Spirometry measures how much air you can breathe out and how fast. In asthma, we typically see an obstructive pattern. Key measurements are the forced vital capacity, FVC, the total amount of air exhaled forcefully after a deep breath, and the forced expiratory volume in 1 second, FEV1, the amount exhaled in the first second. In obstruction, FEV1 is reduced more than FVC, so the ratio FEV1-FVC is decreased, typically below 0.8 or 80% in children. We also look at flow rates, like the FEF 25-75%, which reflects airflow in the smaller airways and is often reduced early.
And variability or reversibility is key.
Yes. Demonstrating significant variability in lung function over time, or significant reversibility of the obstruction after inhaling a short-acting bronchodilator like salbutamol, is highly characteristic of asthma. Suggestive PFT results include significant diurnal variation in peak expiratory flow rate, PEFR, usually measured morning and evening, of greater than 20%, or, more definitively, an improvement in FEV1 of 12% or more and at least 200 milliliter after administering a bronchodilator.
What about chest x-rays in asthma?
A chest X-ray is often performed, especially during a first severe episode or if the diagnosis is uncertain, mainly to rule out other conditions like foreign body aspiration, pneumonia, or structural abnormalities. In uncomplicated asthma, the X-ray is often normal between attacks. During an exacerbation, it might show signs of hyperinflation, air trapping, thickened bronchial walls, bronchial cuffing due to edema, and sometimes patches of atelectasis caused by mucus plugging. But it's not the primary diagnostic tool for asthma itself.
Okay, let's talk management. The goals are clear. Maintain near-normal lung function, allow normal activity levels, prevent troublesome symptoms and recurrent exacerbations, and do all this while minimizing adverse effects from medication. The source emphasizes that asthma cannot be cured, but it can be effectively controlled. This starts with identifying and eliminating triggers where possible.
Absolutely. Environmental control is a crucial part of management plan.
This involves identifying specific triggers for the individual child and taking steps to reduce exposure. Key things include strict avoidance of passive smoking exposure. For dust mite allergy, measures like using allergen-proof mattress and pillow covers, washing bedding in hot water frequently, reducing humidity, removing carpets, especially in the bedroom, and using damp cloths for dusting can help.
What about pets and mold? If there's a clear allergy to a pet, ideally the pet should be removed from the home, or at least kept out of the child's bedroom and off upholstered furniture. Controlling dampness and mold growth is also important, requiring fixing leaks and ensuring good ventilation. Avoiding exposure to cold air or known irritants like strong fumes or sprays is also part of the plan.
Okay, environmental control is step one. Then comes pharmacotherapy, which is the cornerstone, and typically follows a stepwise approach based on severity and control. Let's break down the main drug classes, starting with the rescue medications, the bronchodilators. We have short-acting beta-2 agonists, SABAs, and long-acting ones, LABAs.
Right. The SABAs, like salbutamol, albuterol in the U.S., and terbutaline, are the rescue medications. They work quickly, usually within minutes, to relax the airway smooth muscle and open the airways. They are used only as needed, PRN, to relieve acute symptoms like wheezing or shortness of breath, or sometimes preventatively just before exercise if that's a known trigger.
And the preferred route is inhalation.
Definitely. Inhalation delivers the drug directly to the lungs, leading to rapid onset of action and minimizing systemic side effects compared to oral or injectable forms. The source mentions adrenaline, epinephrine, also stimulates beta receptors but has more alpha receptor effects too, leading to more potential cardiac side effects, so selective beta-2 agonists are preferred.
What about the long-acting beta-2 agonists, LABAs?
LABAs, like salmeterol and formoterol, also relax airway smooth muscle, but their effect is much longer lasting, typically 12 hours or even up to 24 hours for some newer ones. However, their onset of action is slower, maybe 30-60 minutes, so they are not used for relieving acute symptoms.
So what's their role?
They are used as controller medications, specifically for long-term maintenance therapy, usually added on to inhaled corticosteroids when asthma is not adequately controlled by the steroid alone. It's critical to remember that LABAs should never be used as monotherapy by themselves for asthma control, as they don't address the underlying inflammation, and their use alone has been linked to increased risk of severe exacerbations. They must always be used in combination with an inhaled corticosteroid.
Okay, which brings us to the most important drug class for long-term asthma control, the anti-inflammatory agents, primarily inhaled corticosteroids, ICS.
Absolutely. ICS are the cornerstone of controller therapy for persistent asthma. They are potent anti-inflammatory agents that work locally in the airways to reduce the underlying inflammation, swelling, and mucus production that drive asthma symptoms and hyperresponsiveness. Examples include budesonide, fluticasone, beclomethasone, cyclosinide, mometasone. Budesonide and fluticasone are often preferred due to extensive data and favorable safety profiles.
Now, there's always been concern, especially among parents, about potential side effects of long-term inhaled steroid use in children, particularly regarding growth. What does the evidence show?
This is a valid concern and needs to be addressed. Yes, studies have shown that initiating inhaled corticosteroids can lead to a small reduction in growth velocity, particularly during the first year of treatment. The source mentions maybe around 20% reduction in that first year, translating to about 1.5 centimeters less growth on average.
But is this effect permanent? Does it affect final adult height?
The crucial point is that this effect seems to be mainly limited to the first year or two of treatment. Long-term studies suggest that children treated with inhaled corticosteroids generally experience catch-up growth later and ultimately achieve their predicted adult height. The benefits of using ICS to control asthma, preventing severe attacks, maintaining lung function, allowing normal activity are widely considered to far outweigh the risk of this small, largely transient effect on growth velocity, especially when using the lowest effective dose. Regular growth monitoring is still important, of course.
Okay, that's reassuring. What other controller medications are available besides ICS and LABAs? Mast cell stabilizers.
Mast cell stabilizers like cremolin sodium, sodium cromoglicate, and natocromel sodium were used more previously. They work by preventing mast cells from releasing inflammatory mediators. They are considered much less effective than inhaled corticosteroids and are mainly used as an alternative controller option for very mild persistent asthma or specifically for preventing exercise-induced bronchoconstriction. They require regular dosing, often 3 to 4 times a day, and may take several weeks, 4 to 6 weeks mentioned, to show clinical effect. Their use has declined significantly with the advent of more effective options.
What about leukotriene modifiers?
Leukotriene modifiers, like montelukast and zafrilukast, are another class of nonsteroidal controller medication. They work by blocking the action of leukotrienes, which are inflammatory mediators involved in asthma pathogenesis. They are taken orally, usually once a day, montelukast. They are considered less effective than low-dose inhaled corticosteroids for most patients, but can be useful as an alternative controller for mild persistent asthma, or as an add-on therapy to ICS, particularly if allergic rhinitis is also present. Montelukast is approved for use in children as young as 1 year old and is also effective for exercise-induced bronchoconstriction.
And lastly, theophylline. It used to be a mainstay, but less so now.
Yes, theophylline is an older oral bronchodilator with some mild anti-inflammatory effects. Its use has significantly decreased due to its narrow therapeutic window, meaning the effective dose is close to the toxic dose and the potential for significant side effects: nausea, vomiting, headache, seizures, arrhythmias. It requires regular monitoring of blood levels. It's now generally considered an alternative second-line or adjunctive therapy, perhaps sometimes used for controlling nocturnal symptoms if other therapies aren't sufficient. But caution is needed, especially with dosing exceeding 20 milligauge a day due to toxicity risk.
Okay, so we have our toolkit of medications. Now let's walk through the stepwise treatment approach, which is absolutely crucial for mastery in managing asthma, referencing tables 15.8 and 15.9, guided by assessing control levels in table 15.6 and risk factors in 15.7. The goal is to step up therapy if needed and step down if possible to find the minimum treatment that maintains control.
Exactly. The first step is always to assess the level of asthma control. Is it well-controlled, partially controlled, or uncontrolled? This is based on daytime symptoms, limitations on activity, nocturnal symptoms waking, need for rescue SABA use, and lung function, if measurable. We also assess risk factors for future exacerbations.
So step 1 is for intermittent asthma. What does that involve?
Step 1 is for patients with infrequent symptoms, say less than twice a week, brief exacerbations, normal lung function between episodes, and minimal night waking. For these patients, the recommendation is just a short-acting beta-2 agonist. SEBA, taken as needed, PRN, for symptom relief. No daily controller medication is needed.
Okay, SEBA PRN only. What about step 2 for mild persistent asthma?
Step 2 is for patients with symptoms more often than twice a week, but not daily, or night waking maybe once or twice a month. The preferred controller treatment at step 2 is a regular, daily, low-dose inhaled corticosteroid, ICS. The SEBA is still used PRN for breakthrough symptoms. An alternative controller option at step 2, though less preferred than low-dose ICS, could be a leukotriene receptor antagonist, LTRA, like montelukast, or potentially cromolyn, though much less effective.
So daily low-dose ICS is the key addition at step 2. Moving up to step 3 for moderate persistent asthma. What defines this level and what's the treatment?
Moderate persistent asthma usually involves daily symptoms, or night waking more than once a week, some limitation of activity, and maybe reduced lung function. The preferred treatment at step 3 is to increase the controller therapy. The recommended approach is usually low-dose ICS PLVS, a long-acting beta-2 agonist, often available in a single combination inhaler.
So adding the LABA to the low-dose ICS, is there an alternative?
An alternative strategy at step 3, if perhaps the LABI isn't suitable or preferred, is to increase the dose of the inhaled corticosteroid to a medium dose. Adding an LTRA, like montelukast, to the low-dose ICS could also be considered here, but the ICS plus ABA combination is often preferred for better symptom control and convenience.
Okay, step 3 equals low ICS plus LABA or medium ICS. Finally, step 4 for severe persistent asthma.
Step 4 is for patients whose asthma remains poorly controlled despite treatment at step 3, or who have very severe symptoms throughout the day, frequent night waking, significant activity limitation, frequent exacerbations, low lung function. The preferred treatment here typically involves increasing the controller therapy further, usually to a medium or high dose inhaled corticosteroid PLFLUS, a long-acting beta-2 agonist ABA.
So higher dose ICS plus LABA.
Yes. Other add-on therapies might also be considered at this stage, such as an LTRA, montelukast, or sometimes theophylline. Importantly, patients requiring step 4 therapy should definitely be managed by, or in consultation with, an asthma specialist. In very rare, severe cases where control is still lacking, very low-dose, alternate-day oral corticosteroids might be considered by a specialist, but this is a last resort due to systemic side effects.
This stepwise approach provides a clear framework. Now, this leads us directly into the critical discussion about how these inhaled medications are delivered. Why is the choice of inhalation device so important, and why is the standard metered-dose inhaler, MDI, often problematic, especially for children?
The inhalation route itself is fundamentally superior for asthma meds, as we said, direct delivery to the lungs, faster action, fewer systemic side effects. However, the effectiveness relies entirely on getting the drug deposited correctly in the airways. The standard MDI, the puffer, requires precise coordination.
The coordination between pressing the canister and breathing in.
Exactly. The patient needs to start breathing in slowly and deeply just as they actuate the canister, and then hold their breath for several seconds. This is incredibly difficult, if not impossible, for young children, and even many adults struggle with perfect technique.
What happens if the technique is poor?
Most of the drug traveling at high speed from the MDI nozzle simply impacts on the back of the throat, the oropharynx, and gets swallowed, never reaching the lungs where it's needed. This leads to reduced effectiveness and increased potential for local side effects like oral thrush with ICS or systemic absorption from the gut.
So the MDI alone is often ineffective. This is where the spacer device comes in. How does a spacer solve this coordination crisis?
The spacer, or valve holding chamber, VHC, is a simple but revolutionary addition to the MDI. It's essentially a plastic chamber that attaches to the mouthpiece of the MDI. You spray the medication into the chamber first. The spacer slows down the aerosol particles and holds the medication suspended in the chamber for a few seconds.
Decoupling actuation from inhalation.
Precisely. It completely eliminates the need for that split-second coordination. The patient can then just breathe normally, slowly and deeply from the mouthpiece of the spacer, inhaling the medication from the chamber over one or several breaths. The valve system ensures they only inhale from the chamber and exhale out into the room.
And the benefits are significant.
Hugely significant. Spacers dramatically increase the amount of medication that actually reaches the lungs, often doubling or tripling lung deposition compared to using an MDI alone with poor technique. They also significantly reduce the amount of drug deposited in the mouth and throat, thereby reducing local side effects and systemic absorption. The source material emphasizes a key point. Using an MDI with a spacer is considered clinically equivalent in effectiveness to using a nebulizer for delivering bronchodilators during an acute asthma exacerbation.
Even homemade spacers can work.
Yes, the source mentions that even simple homemade spacers, like a plastic bottle adapted appropriately, can be effective in resource-limited settings, highlighting the principle of slowing the aerosol and allowing time for inhalation.
Okay, so if MDI with a spacer is so effective, portable, and often cheaper, why are nebulizers still so commonly used, especially in emergency settings or for young children?
That's a great question. Nebulizers, which turn liquid medication into a fine mist that's inhaled through a mask or mouthpiece over several minutes, definitely still have a role, though perhaps an overused one sometimes. Their main advantage is that they require minimal patient cooperation.
Passive delivery.
Exactly. They allow for passive delivery of the medication during normal tidal breathing. This makes them useful for infants or very young children who cannot reliably use an MDI and spacer, even with a mask. They are also useful for patients who are severely short of breath, distressed, perhaps uncooperative or irritable, or hypoxic during an acute attack, making coordinated use of a spacer difficult.
But they have downsides.
They do. Nebulizers are bulky, require a power source, compressor or oxygen cylinder, take longer to administer the dose, often 5–10 minutes, can be frightening to some children, and may not actually deliver medication more efficiently than a properly used MDI with spacer in cooperative patients. They also require specific flu rates, mentioned as 6–12 lemon, to generate the right particle size for lung deposition.
So the device selection really comes down to the child's age and ability to cooperate.
Largely, yes. For children under about 4 years old, the preferred method is generally an MDI plus a spacer with a correctly sized face mask attached to the spacer mouthpiece. The mask ensures a good seal so they inhale the medication from the chamber. For children over 4 or 5 years old who can cooperate, the MDI with a spacer, using the direct mouthpiece, no mask, is generally preferred. Dry powder inhalers, DPIs, are another option for older children, requiring a forceful inhalation rather than coordination.
Okay, crystal clear on devices. Let's end the asthma discussion by outlining the management of an acute exacerbation, starting with what should happen at home and then moving to hospital triage and treatment.
Right. Every patient with asthma, or their caregiver, should have a written asthma action plan developed with their doctor. This plan outlines how to recognize worsening symptoms and what steps to take. For an acute exacerbation, identified at home typically by increased cough, wheeze, breathlessness, or maybe a drop in PEFR if monitored, the first step is to use their rescue SUBA inhaler promptly.
How much, Amba?
The plan usually involves taking multiple puffs via the spacer. A common approach is 1 puff every 30 to 60 seconds, up to a maximum of maybe 10 puffs, assessing the response. If the symptoms improve significantly and the effect lasts for a few hours, they might manage at home. But if there's no improvement, only partial improvement, or the symptoms return quickly, they need to seek immediate medical attention transfer to the hospital or clinic.
Okay, so prompt SABA use at home, then seek help if needed. Once they arrive at the hospital or clinic, how is the severity assessed? And what are the immediate steps for moderate to severe attacks, referencing table 15.9?
In the hospital, severity is graded based on clinical signs. Alertness sensorium, are they agitated, drowsy? Speech, can they talk in full sentences? Respiratory rate, heart rate, use of accessory muscles, degree of wheeze, oxygen saturation, SpO2, and PEFR compared to their personal best or predicted value. Pulsus paradoxes might also be checked in severe cases.
Let's focus on moderate to severe exacerbations. What's the initial treatment bundle?
For moderate or severe attacks, the immediate priorities are 1. Supplemental oxygen to maintain SpO2 above 92–95%. 2. Inhaled short-acting beta-2 agonists, SA, usually given repeatedly or continuously via nebulizer or frequently via MDI with spacer, DUG, 4–10 puffs every 20 minutes for the first hour. 3. Systemic corticosteroids, oral prednisolone or prednisone at a dose of 1 to 2 mg/kg max, usually 40–60 milligrams, should be given early to all patients with moderate to severe exacerbations to reduce the underlying inflammation. 4V hydrocortisone might be used if oral intake isn't possible.
Okay, oxygen, steroids, the big three, immediately. What if there's still no significant improvement after that initial hour of treatment? What are the next steps?
If the patient isn't responding well after the first hour, EXAMAL PEFR is still low, significant distress continues, we escalate therapy. A key addition is inhaled ipratropium bromide.
An anticholinergic bronchodilator.
Exactly. It works via a different mechanism than SABAs and can provide additional bronchodilation, especially in moderate to severe exacerbations. It's often given combined with the SABA in the nebulizer or via MDI spacer for several doses. If they haven't already received systemic steroids or can't take oral, IV hydrocortisone should be started.
So add ipratropium, ensure systemic steroids are on board. Are there second-line treatments for truly non-responsive severe cases?
Yes, for patients who remain severe despite optimal initial therapy, second-line options may be considered, usually in an ICU or high-dependency setting. Intravenous magnesium sulfate is one option. It acts as a smooth muscle relaxant and can provide additional bronchodilation. The dose mentioned is typically around 50 millikilograms given over 20-30 minutes. Another option, though used less commonly now due to risks, is an IV loading dose of theophylline, aminophylline.
And what defines the most immediate life-threatening crisis requiring ICU admission?
Life-threatening asthma, or status asthmaticus progressing towards respiratory arrest, is marked by signs like confusion, drowsiness, exhaustion, paradoxical chest abdominal movement, the silent chest we discussed, PEFR less than 30% of predicted or personal best, severe hypoxia, SEPPO2 90-92% despite oxygen, potentially rising CO2 levels, hypercapnia, and possible bradycardia or arrhythmias.
And the immediate actions for that.
These patients require immediate aggressive management, often involving the ICU team from the start. This includes high-flow oxygen, continuous nebulized SIBA, possibly combined with ipratropium, immediate IV hydrocortisone, and potentially subcutaneous adrenaline, epinephrine, or terbutaline for rapid effect. They need close monitoring and preparation for potential intubation and mechanical ventilation if they continue to deteriorate or show signs of respiratory muscle fatigue. Transfer to an ICU should happen immediately.
A very clear escalation pathway. Moving into our final section, Section 9X, covering chronic and complex lung diseases. Let's start with foreign body aspiration again, but focusing on the chronic consequences if it's missed initially. It's common in that 1 to 4 year age group, and the initial choking event can be forgotten or unwitnessed.
Exactly. If a foreign body isn't removed promptly, it can lead to persistent or recurrent respiratory symptoms that mimic other chronic conditions like asthma or recurrent pneumonia. The initial choking or gagging episode might be followed by a symptom-free interval, which makes the diagnosis tricky later on.
What's the underlying pathology that causes the chronic symptoms?
It depends on the nature of the foreign body and the degree of obstruction. Organic foreign bodies, like nuts or seeds, peanuts are notorious, tend to absorb moisture and swell over time, worsening the obstruction. If the obstruction is partial, it can create a ball valve effect.
Explain the ball valve effect.
Air can get drawn in past the object during inspiration when the airway widens slightly, but during expiration, the airway narrows, trapping the air behind the object. This leads to progressive hyperinflation of the lung tissue distal to the obstruction. You see localized hyperinflation on an X-ray, often on expiration films, which is a key diagnostic clue.
What if the obstruction is complete?
Complete obstruction prevents air from entering that part of the lung, leading to absorption of the trapped air and collapse, or atelectasis, of the distal lung segment. This collapsed, obstructed area is prone to recurrent infection and inflammation, leading to persistent cough, localized wheezing, or recurrent pneumonia in that specific lung area. Over time, this can lead to chronic suppuration, pus formation, and potentially bronchiectasis.
So persistent localized respiratory signs or recurrent pneumonia in one specific area should always raise suspicion.
Absolutely. Any child with persistent localized wheezing, localized decreased breath sounds, localized hyperinflation or atelectasis on X-ray, or recurrent pneumonia confined to the same lobe or segment should be suspected of having an aspirated foreign body, even if there's no clear history of a choking event.
And the definitive diagnosis and treatment.
Bronchoscopy is required for both diagnosis and removal. Even if the X-ray is normal, which it can be especially with non-radiopaque objects, if the clinical suspicion is high based on history or localized findings, bronchoscopy should be performed. Removal is typically done using a rigid bronchoscope under general anesthesia, as this provides better visualization, airway control, and instrumentation for grasping and removing the object compared to a flexible bronchoscope.
Okay, crucial not to miss that one. Now let's approach the chronic cough more broadly. If a child has a cough lasting weeks or months beyond analyzing the timing and triggers, the character of the cough itself can provide valuable clues.
Yes, the sound and pattern of the cough can be highly suggestive. For example, a repetitive paroxysmal cough, often ending in a whoop or sometimes vomiting, suggests pertussis, whooping cough. A short staccato cough in a young infant might suggest chlamydia trachomatis pneumonia.
What about a barking cough?
A harsh, barking, brassy cough strongly points towards disease involving the larynx or trachea like croup or other laryngotracheal conditions. A very loud, dry, repetitive, almost honking cough that characteristically disappears when the child is asleep or distracted often suggests a psychogenic cough or habit cough, though other causes need ruling out first.
And a wet, productive cough.
A persistent wet or productive cough is always concerning and suggests conditions involving excessive secretions or impaired clearance, like bronchiectasis, cystic fibrosis, primary ciliary dyskinesia, or chronic bronchitis. A cough associated with hawking or throat clearing might suggest postnasal drip from sinusitis or allergic rhinitis. Analyzing the cough's character is a key part of the diagnostic puzzle.
In managing chronic cough, again, cough suppressants are generally avoided unless absolutely necessary.
Correct. The primary goal is to diagnose and treat the underlying cause. Cough suppressants are usually avoided, especially if the cough is productive, as they can impair clearance of secretions. However, if the cough is dry, extremely persistent, exhausting the child, preventing sleep or nutrition, like the severe paroxysms and whooping cough, then judicious use of a suppressant might be considered for symptomatic relief. Dextromethorphan is mentioned as an effective non-narcotic, non-habit-forming option in such cases. Codeine is generally avoided due to potential side effects and risk of respiratory depression.
And physiotherapy plays a role when secretions are the problem.
Yes, chest physiotherapy, including techniques like percussion, clapping, vibration, and postural drainage, positioning the child to help gravity drain secretions from specific lung segments, is essential for helping to mobilize and clear retained secretions in conditions associated with chronic productive cough, such as bronchiectasis, cystic fibrosis, or lung abscess. Airway clearance techniques are a cornerstone of management in these diseases.
Let's discuss those suppurative lung diseases now, starting with lung abscess. What exactly is it, and how does it typically develop?
A lung abscess is a localized area of necrosis, tissue death, and pus formation within the lung parenchyma. It usually arises as a complication of bacterial pneumonia, particularly with virulent organisms like Staphylococcus aureus, Klebsiella pneumonia, or anaerobic bacteria often associated with aspiration.
Can it arise from other causes?
Yes, it can also develop distal to an airway obstruction, like a foreign body or tumor, in an infected congenital lung cyst, or sometimes from spread of infection from elsewhere, hematogenous spread. Staphylococcal lung abscesses, as mentioned earlier, are often multiple.
What's the major risk associated with a lung abscess?
The main risk is rupture. The abscess can erode into an adjacent airway, leading to expectoration of purulent material, which can sometimes help drainage. Or, more dangerously, it can rupture into the pleural space, causing empyema or pneumothorax, pus and air in the pleural space.
How is it treated?
Treatment primarily involves prolonged antibiotic therapy, typically for 4 to 6 weeks or even longer, guided by sputum culture and sensitivity if possible, or based on likely pathogens. Intravenous antibiotics are usually needed initially, followed by oral therapy. Physiotherapy with postural drainage is crucial to help drain the abscess cavity via the airways. Surgical intervention, drainage, or resection is generally reserved for abscesses that fail to respond to medical therapy, are very large, or have complications like rupture.
Okay, now on to bronchiectasis. This is defined as a chronic condition involving irreversible dilatation and destruction of the bronchi. What leads to this permanent damage?
Bronchiectasis is essentially the end result of chronic inflammation and infection, leading to destruction of the elastic and muscular components of the bronchial walls. This damage causes the airways to become permanently widened, flabby, and distorted. This abnormal structure impairs normal mucus clearance, leading to pooling of secretions, chronic infection, and a vicious cycle of further inflammation and damage.
What are the common underlying causes that initiate this process in children?
It often follows severe or recurrent lower respiratory tract infections, especially necrotizing pneumonias that may have occurred in early childhood, perhaps post-measles or post-pertussis pneumonia before widespread vaccination. Cystic fibrosis is a major cause of bronchiectasis due to the underlying defect in mucus clearance.
Any other important causes?
Yes, conditions causing impaired airway clearance like primary ciliary dyskinesia are important causes. Foreign body aspiration, if retained long-term, can lead to localized bronchiectasis distal to the obstruction. Extrinsic compression of an airway, for instance by enlarged tuberculous lymph nodes compressing the right middle lobe bronchus, leading to middle lobe syndrome, can cause chronic collapse and infection, resulting in bronchiectasis in that lobe. Immunodeficiency states also predispose to recurrent infections and potential bronchiectasis.
What's the typical clinical presentation? Is it obvious?
The onset is often insidious. The child might have a history of recurrent chest infections, poor weight gain, or generally poor health. Clubbing of the fingers and toes is a common physical sign in established bronchiectasis. The hallmark symptom, however, is a chronic, persistent, productive cough, often producing copious amounts of thick, purulent sputum, phlegm. This is typically worse in the mornings or after lying down for a while, due to pooling of secretions overnight. Recurrent episodes of fever and increased cough, exacerbations, are common. Hemoptysis can also occur.
How is bronchiectasis diagnosed definitively now? It used to involve bronchography, right?
Yes, bronchography, injecting contrast dye into the airways, used to be the gold standard but is invasive and rarely performed now. The current diagnostic tool of choice is high-resolution computed tomography, HRCT, of the chest. HRCT provides detailed images of the airways and can clearly show the bronchial dilatation, wall thickening, and associated changes characteristic of bronchiectasis, often revealing the extent and pattern of disease. Other investigations are aimed at finding the underlying cause, like a sweat chloride test to rule out cystic fibrosis, test for immunodeficiency, or ciliary function studies.
And the management. Is it
Yeah.
curative?
Bronchiectasis itself, the structural damage, is irreversible. So management focuses on controlling symptoms, preventing progression, and treating the underlying cause if possible. Key components include 1. Airway clearance techniques. Regular, often daily chest physiotherapy and postural drainage are vital to clear the excessive secretions and prevent stagnation and infection. 2. Antibiotics, used promptly to treat acute infectious exacerbations, often guided by sputum culture. Sometimes long-term rotating or prophylactic antibiotics are used in severe cases with frequent exacerbations to try and suppress bacterial load. Inhaled antibiotics might also be used. 3. Bronchodilators may be helpful if there's associated reversible airflow obstruction. 4. Addressing the underlying cause, essential if one is identified, e.g. managing CF, treating TB, removing foreign body.
What about surgery?
Surgical resection of the affected lung segment or lobe is only considered in a small minority of cases where the bronchiectasis is clearly localized to one area of the lung. Medical management has failed to control symptoms adequately, purity, persistent severe cough, recurrent hemoptysis, and the remaining lung tissue is healthy. It's not a common treatment anymore with improved medical management.
Okay, that provides a good overview. Now let's tackle cystic fibrosis, CF itself. It's described as the most common life-limiting autosomal recessive disorder, particularly in Caucasian populations. What's the fundamental genetic defect?
CF is caused by mutations in the gene located on chromosome 7 that codes for a protein called the cystic fibrosis transmembrane conductance regulator, or CFTR.
CFTR protein, what does it normally do?
CFTR normally functions as a channel protein, primarily regulating the movement of chloride ions, and indirectly sodium and water, across the surface of epithelial cells, particularly in the lungs, pancreas, intestines, sweat glands, and reproductive tract. There are many different mutations known, but the most common one worldwide is called delta F508 or EP508 et al.
And when this CFTR protein is defective due to the mutation, what's the core pathophysiological consequence?
The fundamental problem in CF is the failure of proper chloride conductance across the cell membrane. This disrupts the normal balance of salt and water transport. The key result, especially in the airways and pancreas, is the production of abnormally thick, viscous, dehydrated secretions because water doesn't follow the chloride out onto the surface properly.
So thick, sticky mucus everywhere.
Essentially, yes. This thick mucus is incredibly difficult to clear from the airways, leading to obstruction, chronic bacterial infection, often with specific pathogens like Pseudomonas aeruginosa, persistent inflammation, and progressive lung damage, culminating in bronchiectasis and respiratory failure. In the pancreas, the thick secretions block the pancreatic ducts, preventing digestive enzymes from reaching the intestine, leading to malabsorption.
What are the main clinical manifestations we see in children with CF, resulting from this widespread secretion issue?
The presentation can vary depending on the specific mutations and age. In newborns, about 10–15% present with meconium ileus, a blockage of the small intestine by abnormally thick meconium. In infancy and childhood, recurrent respiratory problems are hallmarks, persistent cough, recurrent bronchiolitis or pneumonia, Eventual chronic lung disease with bronchiectasis, which develops in about 70% by age 13.
And the pancreatic insufficiency.
Yes, pancreatic insufficiency leading to fat malabsorption, staturia, bulky, greasy, foul-smelling stools, and failure to thrive occurs in over 85% of patients. Other manifestations can include chronic sinusitis, nasal polyps, salt loss syndromes, CF-related diabetes, liver disease, and in males, infertility due to absence of the vas deferens, azoospermia in 98%. The diagnosis is usually suspected based on the typical clinical phenotype symptoms. A positive newborn screening test, now common in many regions, usually measures immunoreactive trypsinogen, IRT, or a family history of CF. Confirmation relies on demonstrating dysfunction of the CFTR protein. The gold standard diagnostic test is the quantitative pilocarpine iontophoresis sweat test, the sweat chloride test.
What result confirms CF?
A sweat chloride concentration consistently greater than 60 millieql on at least 2 separate occasions is considered diagnostic of CF. Values between 30–59 millieql are considered intermediate or borderline and require further investigation, often including genetic testing to identify specific CFTR mutations. Identifying 2 known disease-causing CFTR mutations via genetic analysis also confirms the diagnosis.
Management of CF is complex and lifelong, requiring a multidisciplinary team. What are the main pillars of care?
Management is intensive and aims to maintain lung health, ensure adequate nutrition, and manage complications. Key pillars include 1. Respiratory management. Aggressive airway clearance techniques, physiotherapy devices, multiple times daily are essential. Inhaled meditations like bronchodilators and mucolytics, for example, Dorney's alpha-hypertonic saline, help thin secretions. Chronic antibiotic therapy, inhaled, oral, or IOV, is often needed to suppress chronic bacterial infections, especially Pseudomonas. Anti-inflammatory agents may also be used. Newer CFTR modulator therapies targeting the specific protein defect are revolutionizing care for eligible patients. 2. Nutritional care. Requires a high-calorie, high-fat diet to compensate for malabsorption and increased energy expenditure. Pancreatic enzyme replacement therapy, Pureit capsules must be taken with all meals and snacks containing fat or protein. Supplementation with fat-soluble vitamins A, D, E, K is crucial due to malabsorption. Close monitoring of growth is essential.
It's truly a multi-system disease requiring comprehensive care. Let's close this section with a brief look at Acute Respiratory Distress Syndrome, ARDS. How is it defined, and what's the underlying mechanism?
ARDS is a devastating form of acute, diffuse, inflammatory lung injury leading to increased pulmonary vascular permeability and non-cardiogenic pulmonary edema. It's essentially acute respiratory failure, not originating from heart failure.
What triggers this massive inflammatory response in the lungs?
ARDS is usually triggered by a significant underlying insult, either direct lung injury, like severe pneumonia, aspiration, near drowning, inhalation injury, or indirect injury from a systemic inflammatory process, like sepsis, severe trauma, pancreatitis, multiple blood transfusions. The common pathway involves massive activation of the inflammatory cascade within the lungs,
Leading to leaky capillaries.
Exactly. There's increased permeability of the alveolar capillary membrane. This allows protein-rich fluid to flood the alveoli, inactivating surfactant and causing widespread alveolar collapse, atelectasis. There's also aggregation of neutrophils and release of inflammatory mediators like cytokines and oxygen radicals, causing further vascular and epithelial injury. Hyaline membranes, composed of cellular debris and proteins, form in the alveoli, further impairing gas exchange. If the patient survives the acute phase, fibrosis can develop later.
What are the clinical hallmarks?
The clinical picture is characterized by the acute onset, usually within 672 hours of the inciting event, of severe hypoxemia, low blood oxygen levels, that is refractory to supplemental oxygen alone, requiring mechanical ventilation. Patients also often develop hypercapnia, high CO2. Chest X-ray typically shows diffuse, bilateral, hazy opacities or infiltrates, consistent with widespread pulmonary edema.
And the prognosis is grim.
Unfortunately, yes. Despite advances in supportive care, mortality from ARDS remains very high, often cited in the range of 30–50%, depending on the severity and underlying cause.
How is it managed?
Management requires intensive care unit, ICU support. The cornerstone is mechanical ventilation, typically using a lung protective strategy with low tidal volumes to avoid ventilator-induced lung injury, and relatively high levels of positive end expiratory pressure, PEEP, to help keep the damaged alveoli open and improve oxygenation. Meticulous fluid management is crucial to support organ perfusion without worsening pulmonary edema. The most important aspect is aggressively treating the underlying cause that triggered the ARDS, AG antibiotics for sepsis, source control for infection. There are no specific pharmacological therapies proven to reverse ARDS itself.
A truly challenging critical care scenario. We have certainly covered an immense amount of ground today, really traversing the full spectrum of pediatric respiratory health, from the intricate mechanics of that very first breath all the way to the pathology of chronic destructive lung diseases like CF and bronchiectasis. The level of clinical mastery required, especially in those rapidly deteriorating situations like severe croup or life-threatening asthma attack, is just profound.
It really is. And throughout this deep dive, we've tried to highlight those subtle but absolutely critical distinctions that define expert practice. Things like knowing the specific age-based cutoffs for rapid breathing in the WHO pneumonia assessment, or understanding the fundamental pathological difference between staph causing destructive pneumatoxylase versus pneumococcus causing consolidation, and remembering counterintuitive dangers like the silent chest in severe asthma where lack of sound means extreme danger, not improvement.
Exactly. And maybe one of the most consistently frustrating challenges we touched upon, particularly in asthma management, relates to optimizing therapeutic delivery. We have these incredibly effective inhaled medications, especially the inhaled corticosteroids and bronchodilators delivered via MDI. They're portable, efficient, minimize side effects. Yet their effectiveness hinges almost entirely on perfect patient technique and coordination.
Which, as we discussed, is often the biggest hurdle, especially in toddlers or young children during the distress of an attack. This reliance on technique frequently forces clinicians towards using the bulkier, potentially less efficient nebulizer, simply because it allows for passive delivery. The success of outpatient asthma control, in many ways, rests precariously on the patient's or caregiver's ability to master that MDI spacer technique.
The hardware, the MDI and spacer combination, is arguably superb technology, offering targeted delivery with minimal systemic impact. But the software, the human ability to use it correctly under pressure or when very young, often falls short.
It's a classic interface problem, isn't it? The technology meets the limitations of the developing or distressed patient.
So, building on that specific challenge, here is our final thought for you, the listener, to consider. Given this critical reliance on proper technique for MDI and spacer usage, especially in the youngest and often most difficult to treat patients, how might emerging technologies, perhaps AI-powered feedback devices connected to the spacer, or even gamified physical training apps designed to teach correct inhalation maneuvers, how might these revolutionize the success rate of MDI usage? Could they provide the real-time feedback and correction needed to bridge that technique gap, potentially shifting the clinical balance significantly away from the reliance on nebulizers, even in many acute, non-severe situations?
That's a fascinating prospect, essentially using technology to optimize the patient's ability to use the existing effective hardware, turning that interface challenge into an immediate advantage through guided learning and feedback. Definitely something to watch, and perhaps a future deep dive topic itself.
Indeed. Food for thought. Until next time on The Deep Dive.